Well, good morning. Thank you so much for joining me today. I'm really excited to be presenting to you the product that we have in front of you here, FERAPRO. My name is Ying. I'm a registered pharmacist, and I am going to be hopefully convincing you by the end of this session why FERAPRO is the next standard for oral iron therapy in Canada. So these are our learning objectives for this morning. We're going to take a quick overview of the pathophysiology of iron deficiency. We're going to talk briefly and generally about how we tend to treat or approach treating iron deficiency, and then we're going to dive into why FERAPRO is the superior product. All right, to start with, just a quick overcap of iron deficiency anemia, a review. I'm sure we remember all of this from school. Why do we care so much about iron deficiency anemia? Well, it's actually the most common nutritional disorder in the world. 1 in 3 people worldwide have a form of anemia, and half of those people, it's iron deficiency anemia. So it's an extremely common disorder, and it's a disorder that's not just in developing countries. It's something that is quite predominant even in North America, so something that definitely matters to our average patient. Why is iron so important in our bodies? Well, we know iron is essential in the formation of hemoglobin, and it's hemoglobin that carries oxygen from the lungs to every tissue in the body, every cell in the body, for them to make energy. And it's the hemoglobin that also brings the carbon dioxide back to the lungs for excretion. So for each hemoglobin, we have 4 ions of iron, and for 1 red blood cell, we have 270 million molecules of hemoglobin. So it goes to show you how important and essential iron is to our very survival. This is the general breakdown of how iron is distributed through the body, and we have an average adult woman as our sample population. The reason being it's the average adult woman that's going to be at higher risk of iron deficiency to begin with. You'll see that most of the iron is distributed in the red blood cells, and it's interesting to point out that we don't actually lose the iron in those red blood cells when they turn over. Our body is meticulous at recycling that iron back into the system. So in actuality, we only lose about 1 to 2 milligrams of our body's iron per day, and that's just from sloughing of skin cells and enterocyte cells. Our bodies are really, really good at recycling that iron. I think that's a testament as to why iron is so important in the body. We want to hold on to it as best that we can. So usually, because we're only losing 1 to 2 milligrams of iron, we're only really absorbing 1 to 2 milligrams of iron from our dietary intake. But sometimes there's things that set off that balance. For example, menstruation, we can lose up to 100 milligrams of iron in a single day. So that's a huge difference. And it's when these disbalances are not offset by an increase in absorption that iron deficiency can happen. So this is a quick overview of how iron homeostasis is maintained in the body. It's really, really important to know and to explain to your patients that there is no active excretory pathway for iron in the body, meaning that iron homeostasis is entirely and solely dependent on gastrointestinal iron absorption. So there's only 2 transporters in the body that are responsible for iron absorption and hence iron homeostasis in the whole body. So we have the first one, it's HCP1. This one is the transporter that brings in heme iron. The heme iron is the iron that we get from animal sources. It's already in a protein complex that has really no trouble getting through with the HCP1 receptor. And the second receptor that we have, transporter rather, which brings in non-heme iron in the ferrous form, is DMT1. And it's up or down regulation of these 2 transporters that mediates all of our iron homeostasis based on our body's needs. So taking a closer look at the difference between heme iron and non-heme iron, heme iron from our diet has pretty good bioavailability, about 20 to 25% of it gets absorbed. When we compare that to non-heme iron, which is from plant sources, we see that the bioavailability is much more variable and generally lower, so from 2 to 20%. And why is it so variable? Well, it's another important thing to note, and maybe to educate your patients, that non-heme iron is available in two forms. There's ferric iron and ferrous iron. Now, ferric iron is the form that iron usually exists in our soil, and hence the form that comes from our diet, from our plant sources. And ferric iron, you see, can't actually cross that DMT1 transporter. It has to be converted by this enzyme into ferrous iron before it's able to be absorbed. And another important thing to note is that the cofactor required for this reaction is vitamin C. We always tell our patients we want to take vitamin C with our iron. This is exactly why. So ferrous iron is the only form that we can actually absorb, and ferric iron is the form that we're getting from most of our plant sources. It's also the form that exists if our stomach pH is too high. So we'll get into some of the factors that inhibit absorption later on today. So when does iron deficiency happen? It happens if the rate of loss is not offset by an equal rate of absorption. So loss is greater than gain. We have a depletion of iron stores in the body that eventually leads to anemia. And there's lots of different causes. So we've categorized these causes. First one being increased loss, of course. So if we have an ongoing bleed, an unresolved bleed, we're going to be losing iron faster than we are gaining it through our diet. So GI bleed and ulceration, menstruation and menorrhagia is a huge risk factor for iron deficiency anemia. People who donate blood regularly, this one I think is often overlooked. You get your hemoglobin tested at the blood clinic, but they don't often, to my knowledge, test ferritin. And you can be depleting those ferritin stores before that ever gets reflected in hemoglobin until it's too late. So regular blood donation certainly is an increased risk. We have elite athletes. So one of the only other ways that we're losing iron is through our sweat, through profuse sweating. And being a room pharmacist, we always want to talk about drug-induced nutrient depletions. And of course, drugs that increase risk of bleeding are going to be on this list. NSAIDs, aspirin, your blood thinners, NOACs, etc. Another category that of risk would be decreased intake. So dietary intake is really important. And that can range from somebody who just generally has a poor diet to very restricted diet. And we're seeing more and more of this now. I think it's more and more of a trend for people to have restricted diets. So vegetarian and veganism, those are really big risk factors because they're not getting that heme iron, which is more readily bioavailable. Another risk factor, malabsorption. So if we're not absorbing through our GI tract, that's our main mechanism for iron homeostasis. We're losing out on that body's ability to regulate iron. So chronic conditions like celiac disease, we have H. pylori, patients who have GI resection, ostomies, etc., they're not going to be able to absorb iron as readily. Certain foods are really going to be competitive against dietary iron absorption. So we know high fiber foods, leafy greens, calcium in dairy products are going to compete for absorption. Tea and coffee are two huge ones. They actually contain phytates that are really big culprits at binding to iron and not allowing absorption. I think a lot of patients take their iron first thing in the morning with their coffee, not realizing that it's the coffee that's really inhibiting the absorption. And I didn't put this in here, but drugs, we want to talk about drugs. So going back to that slide regarding the ferric versus ferrous iron, if we have physiologic pH, which is about 7, iron goes into the ferric form. And that happens if we take drugs like PPIs and H2RAs. So for patients who are on chronic PPIs, chronic H2RAs, they're not going to be absorbing their dietary iron nearly as well, especially if they're not also taking vitamin C. So we want to be assessing that risk factor as well. And finally, just general increased requirements. So in growth spurts, children are at higher risk of iron deficiency anemia, and that's often overlooked. Adolescence, so the onset of menarche is another big one, and of course pregnancy. Our iron requirements to sustain us through pregnancy go up really high, so that's a group that we want to be looking at, not only treating iron deficiency, but also preventing it. So I think we as pharmacists are uniquely positioned to be able to identify at-risk patients. We have access to these patients' medical history, medication list. They're telling us their symptomology as well. So I think just being able to risk stratify them, put them in your head into these risk categories, and then recommending and encouraging them to seek lab work through their GP and monitor their ferritin level if you think they're at high risk is really important. And that'll really help to build that patient rapport. How does iron deficiency present clinically? It seems to present in a pretty non-specific way. There can be symptoms of iron deficiency anemia from head to toe. So we know our classic symptoms. We have fatigue, we have exercise intolerance, shortness of breath. We also have a risk of alopecia, so hair thinning and falling out and dry skin. We have actually one of the only things that's been shown to help with restless leg syndrome, which is notoriously difficult to treat, is iron, because restless leg syndrome is associated with low iron. So this is in your pamphlet for a closer up, but an overview. And if you see these clinical presentations in your patient, another good reason to recommend that they get tested. And finally, diagnosis. So beyond the clinical picture, the gold standard for diagnosing iron deficiency anemia is by taking a serum ferritin level. So anything under 15 micrograms per liter is an automatic diagnosis of iron deficiency anemia, and that requires prompt oral treatment. Between 15 and 50 micrograms per liter, we have a probable deficiency, and these patients may or may not have functional anemia, and they may or may not already be presenting with clinical symptoms. So even in this category, we can consider treatment to top up their body iron stores. Between 50 and 100 micrograms per liter, it's a possible deficiency, especially if we're seeing a trend lower and lower, so we can consider prophylactic therapy in this group. And then over 100, they're probably in the clear. If we see, and this is rare, but if we do see patients with high iron, over 1,000 micrograms per liter, that can be a sign of iron overload, so chronic overdosing of iron, and that does require further investigation, so we'll be talking about that as well. Beyond serum ferritin, some other lab work, our red blood cells are going to start looking different. So they're going to get microcytic and hyperchromic, meaning they're getting smaller and they're getting paler because they're not filled with as much hemoglobin. And we are seeing elevated TIBC, so total iron binding capacity, that's showing that the body's holding on to all of the iron that it has for dear life because it's not got very much. So now that we know how iron deficiency works and how to treat or how to identify it, let's look at how we generally treat it. So there's kind of two principles of therapy, and we want to be addressing both of them. First is to resolve the underlying cause. So iron deficiency doesn't just happen. There's usually a root cause of the problem, whether it's an ongoing bleed like a GI ulcer or menorrhagia, or frequent blood donation. Often it's the first sign that there's something else going on and we really want to treat that underlying cause. If we can, we want to remove offending drugs, so drugs that increase bleeding like NSAIDs, and drugs that reduce absorption like PPIs and H2RAs. Sometimes we can't discontinue these drugs. People who have blood thinners on board need those blood thinners, but we do what we can. And we want to also be assessing dietary intake of iron. Sometimes patients just are not aware that they don't have enough dietary iron on board, and that sometimes is enough to rectify the situation. But if they are indeed deficient, we also want to be restoring the body's iron supply through supplementation. We have two options. We have the oral supplementation, which is far and wide preferred, and if that fails, then we can go parenteral as well. But oral supplementation is so much safer and much less invasive, so we definitely want to maximize that before we go parenteral. So with oral supplementation, the daily recommended dose is pretty straightforward. So for children, it's dose based on body weight, 3 to 6 milligrams per kilogram per day, up to the adult maximum, of course. For adults, really straightforward, 100 to 200 milligrams of elemental iron per day. And then in pregnancy, we want to risk stratify. So if they're not already anemic, we still do want to give them extra iron to prevent anemia because it is so common. So we can increase iron intake up to 30 milligrams. And if they are indeed deficient, then we would treat them as we would any other adults, 100 to 200 milligrams elemental iron a day. There is a notion that dividing the oral iron dose might be better because it might be better tolerated. But recent literature has come out to show that if we divide the daily dose into twice a day or 3 times a day, our bodies are actually not going to be absorbing that second or third dose very effectively. Because we know that our body is regulating the absorption so stringently, it's actually quite smart. So it's not going to be absorbing if we divide the dose. It's actually better to give a once a day or even alternate day dosing to maximize absorption. And alternate day dosing might be another option if they're not tolerating it as well. So something important to think about. When it comes to what's on market right now, the types of oral iron therapy, we can kind of break them down into 3 categories. So we have our heme iron, we have ferrous iron salts, and we have our polysaccharide iron, so FERAPRO. With heme iron, there's some advantages and some disadvantages. So the heme iron, being that it is heme iron from the animal source, it generally is pretty well absorbed and tolerated. But the dose per unit tablet is really low, so it's only 11 milligrams of elemental iron per tablet. It's hard to put that in perspective when the recommended dose is 100 to 200 elemental, and their argument is that because it's better absorbed, we don't have to take as much. But if you dig into the literature, there's actually not a lot to support using heme iron at this low dose for treatment of iron deficiency in general. So the only studies that they've been able to put out is treating iron deficiency in patients who have chronic kidney disease. So the evidence is actually quite sparse when it comes to heme iron for treating iron deficiency in our general population. We know it's probably good for prevention, but we don't necessarily know, based on the studies, if it's enough for treatment. And of course, being that it's an animal source product, it would not be suitable for our vegetarian and vegan patients. And we have our good old ferrous iron salts. These are our generic irons. They supply iron in the ferrous form, which we know is good because it'll actually get absorbed through that transporter. And we kind of have 3 general types of iron salts that we see on market. So we have ferrous fumarate, ferrous sulfate, and ferrous gluconate. And they will vary based on their content of elemental iron. So ferrous fumarate gives us the most. It's 33% elemental iron. Ferrous sulfate's in the middle, 20%. Ferrous gluconate, only 12%, which means that they have to take quite a bit to get up to that target dose per day. And finally, we have polysaccharide iron, which is FERAPRO. So it's important to note, if you take a look at the molecular structure of FERAPRO, that the iron molecules in that structure are actually in the ferric form, which means that it has to be converted then in the body to the ferrous form before it's able to be absorbed. So ferric iron tends to be less bioavailable. It has to be converted. And polysaccharide irons give off the claim that it's better tolerated than traditional irons, but we actually don't have the literature to back that claim up either. So now that we have our treatment options, how do we monitor for our safety parameters, so our side effects and our toxicity? Well, we know that one of the downfalls of iron therapy is that it can cause side effects that are not tolerable for patients. So nausea, upset stomach, constipation are our main culprits. So what are some strategies we can implement to lower these risks? Well, one thing that I found that actually does work is starting low and going slow. So our body does develop tolerance to these side effects over time. So if we start at a lower dose and gradually increase, although that may mean that it takes longer to rectify the anemia, at least they're tolerating the iron over time and not just discontinuing therapy. Another strategy that we see that we talked about a little bit is splitting the doses twice a day or 3 times a day, but we know that that might reduce absorption. So a little bit of iron is better than no iron, but just know that that might not maximize our absorption. Taking it with food, same thing, it might reduce absorption, but if it means that the patient is able to tolerate the iron, then eventually we can work up to empty stomach dosing. We have enteric-coated and control-release tablets on market like Slow FE, but we know that these products don't absorb very well. They might be better tolerated, but it's going to take a really, really long time to rectify the anemia if we rely on these products. Another important thing to tell the patient is that iron therapy can cause dark stools, and that is generally harmless. It's a sign that the stool is oxidizing, which means that some of the iron is not getting absorbed, but it's not harmful. It is important, though, to differentiate those dark stools from other types of dark stools that might indicate things like GI bleed, so important to counsel your patients on that. And of course, liquid irons, they can stain the teeth, but these stains tend to be quite superficial. So it might be really off-putting to your patients, but encourage them that these stains are removable with just baking soda infused toothpaste, and that they can take iron through a straw, and that would minimize the risk of staining. So beyond these really common side effects, we also do have a risk of toxicity. Of course, this is why we keep high-dose iron behind the counter. Because acute toxicity can happen at doses over 40 milligrams per kilogram, and in kids, there is enough iron in a bottle behind the counter to be potentially fatal. So it's really important for patients to be aware of that. At acute toxicity, we can see presentation like vomiting blood and GI bleed, leading to hypotension, leading to shock, leading to organ failure, and even death, so it can be quite serious. But aside from acute toxicity, we can also have chronic iron overload. And remember, our bodies have no way of actively excreting the iron that it's able to absorb. So if a patient is supplementing and supplementing and supplementing and not being followed by a practitioner and not being counseled, there is a risk that they're taking too much iron and the iron is depositing in places that it shouldn't go. And how does that manifest? We see hepatic cirrhosis, we see increased risk of diabetes and cardiovascular disease, we see risk of skin pigmentation. So again, a really important counseling point here as well. If oral therapy fails, we have to go parenteral. And this is no fun at all. This is something we want to avoid. So IV therapy, it is much less safe. It's invasive. The patient has to go to a medical daycare to get an IV put in. Oftentimes we have to do a test dose to minimize the risk of anaphylaxis. So it's not fun for the patient and something that we want to avoid as much as possible. We have a couple of different forms of IV iron, but usually they'll be followed by a hematologist at this point. We generally want to avoid IM iron because the absorption from intramuscular injection tends to be a lot less predictable, and we have a higher risk of anaphylaxis, much more pain when we're absorbing iron through the muscle, and a risk of sarcoma forming, risk of staining, so something we want to avoid as well. So now that we have them on a pretty good iron regimen, how do we monitor to make sure it's working? Well, within the first 7 days, we're already seeing our reticulocyte count go up, and those are immature red blood cells, so it indicates a shift in the right direction that we're rapidly making more red blood cells. After about a month, our hemoglobin's up. After about 2 to 4 months, the anemia itself is corrected, but we usually want to supplement beyond that to 8 to 10 months to really top up those body iron stores. So now that we've talked in general about how to treat iron deficiency, I really want to dive in and talk about what makes FERAPRO different and how FERAPRO is really going to be optimizing oral iron therapy in a way that other commercial products are not right now. So what is FERAPRO? You all have a bottle in front of you. It's a clinically proven and evidence-based formula. We've put 5 ingredients together and they're designed to have a unique role that each of them play to optimize oral iron therapy. We have 3 strengths available, so 30 milligrams, 75 milligrams, and 150 milligrams. And that's really going to empower the patient and yourselves as the practitioner to find the dose that's best for them at the place in therapy that they need it. So this slide is an overview of the ingredients, and we're going to be talking about each and every one of them, why they're in the formula. And you'll see that the dosing is slightly different based on the strength that you have. So going into each individual ingredient, these are medicinal ingredients. The first and foremost, of course, is iron. And the iron that we've put in there is in the form of ferrous fumarate. So why do we choose ferrous fumarate? Well, first, it's a ferrous iron form, which means that it's going to be absorbable. We have ferrous fumarate, which is the highest elemental iron content, which means that we can have a higher dose per unit capsule compared to the other forms of ferrous iron salts. In fact, the FERAPRO product is the only product on market that offers 150 milligrams of elemental iron in a single dose. Aside from that, we have vitamin C, ascorbic acid. You'll remember that ascorbic acid is a really important cofactor for the enzyme that converts ferric iron to ferrous iron. You might be asking yourself, why do we care about that if this product is already in ferrous iron form? Well, if you'll recall, in physiologic pH, our bodies actually convert the iron back and forth, and if the pH is too high, the iron's going to get sent back into the ferric form. So the vitamin C is in there kind of as an insurance policy to make sure that we're converting as much of that iron into the ferrous form for absorption as possible. And in the literature, in fact, we do see that taking an appropriate dose of vitamin C with our non-heme iron can increase bioavailability by 1.5 to 10-fold, which is quite significant. Aside from those 2 ingredients, we also have some other important cofactors. So we have vitamin B12, and we have vitamin B12 in its most bioactive form, methylcobalamin. So 2 questions here: why do we need B12, and why is it important that it's methylcobalamin? We need B12 because the final step of red blood cell synthesis requires the methylation of DNA. So B12 is essential as a cofactor for that pathway. And methylation of DNA is important because these red blood cells are turning over so quickly. The other important factor is that it's in the biologically active form. So if we see a B12 supplement off the shelf, most of them are going to be cyanocobalamin. The body has to do the extra step of converting that to methylcobalamin before it's able to use the B12 in this pathway. We've taken that step out, so the body doesn't have to do it. Not everybody is really good at that conversion rate in the first place, so we've put it in its most active form for that biological pathway. And similarly, folate is essential in that same pathway. And folate in here is represented in its biologically active form, 5-methytetrahydrofolate, which is a mouthful. Your patients are going to see that on the label and say, what the heck is that? I don't know that chemical. I don't want to take this. So that's another really important thing for you as a practitioner to be able to explain. That is the active form of folate, and it's essential for the creation of new red blood cells. Finally, we have glycine. This is our magical ingredient. So glycine is an amino acid, and what it does when it's in this formula, when it gets solubilized in the body, is it forms a chelate complex with the iron ion. So we know, for example, other products that form a complex with iron that's touted to be more bioavailable and better tolerated. Well, we do have literature, in fact, that iron, when it forms a complex with glycine, is much easier on the stomach, less incidence of nausea and constipation without affecting the bioavailability. So glycine is in there to chelate with the iron and make it easier on the stomach. We talked about the medicinal ingredients in FERAPRO, but I think equally important is touching on non-medicinal ingredients. These are a factor of supplements that our patients are increasingly aware of and increasingly picky about. So what stands FERAPRO apart from the other leading brands is that it is so clean. There's only one other ingredient, and it's hypermellose. So hypermellose is a hypoallergenic vegetable-based ingredient, and it forms the vegetable capsule that encapsulates the other ingredients. That's it. When you compare it to the other products like Palafor, FeraMax, and Proferin, you'll see, for example, dyes and preservatives to which some patients have sensitivities. You'll see that some other products like Palafor contain gelatin and lactose, so that might not be tolerable or suitable for our vegetarian and vegan patients. FERAPRO does a really good job of being absolutely clean of all of those ingredients. We have this product in front of you, and you're explaining to your patient why it is superior. So these are kind of the overview of how we can explain that advantage to our patient. So we know that it's gentle and effective from our clinical trial. We know that it's free of preservatives and dyes and common allergens like dairy, gluten, corn, soy. We know that it's vegan friendly when not all other irons are, and that's so important because it's those patients that are at highest risk of iron deficiency. But aside from that, it's packaged in glass, which I know sounds a little bit trivial, but you'll see that more and more patients are really cognizant of single-use plastics, and that actually might be a big advantage for them. It's available in 3 different doses, which you don't see in other irons. And those 3 doses are going to give you the flexibility to choose the right dose for the patient. I think we often neglect thinking about things like prophylactic iron therapy, but the lower end of the doses might be really good for those patients, and we'll go into that a little bit. And finally, it's affordable. So when you line up all of your irons on your shelf, they might be looking at, their generic ferrous gluconates and saying, why would I pay so much more for FERAPRO? Well, if we look at this comparison chart here, the bottom row shows you a comparison of the different irons on market in their brand names compared to FERAPRO at price per capsule. So we set the price based on 150 milligrams of elemental iron per dose. And you'll see that FERAPRO is 60 cents per 150 milligram daily dose. If we compare that to Palafor, depending on the Palafor product that you get, whether it's a 30-pack or a 100-pack, that'll vary between 58 cents and 85 cents. Palafor is just ferrous fumarate. That's it. Nothing else in there. We also have ferrous sulfate in its brand form, which is Ferinsol, and that's 68 cents per unit dose. We have Fluoridix, which gives you ferrous gluconate, ridiculously expensive. We have over $9 per unit dose. We have FeraMax, which is our comparator. That's more expensive, so 85 cents per unit dose. And Proferin. Proferin, we couldn't do 150 milligrams elemental because it's heme iron, but we took their recommended dose, which is 3 tablets a day, and that works out to be $3 per recommended dose. So if we put this in perspective for the patient, FERAPRO is actually on the lowest end of that price spectrum, makes it probably the most worth it at its price. So we have our product, we know that it works, we know that it's the most price conscious. How do you initiate that conversation with your patients? So in my practice, I kind of see different categories of patients. I see patients who I know their medications and their medical background, and I know how they're presenting clinically, but they've never been investigated for iron deficiency. So in these patients, I'm risk stratifying in my head. I'm seeing what their medications are, and they're coming up to me and telling me, I'm so tired, my hair is falling out. I'm going to be telling them, get your iron tested and get your thyroid tested through your doctor. That's the first step. And if you're able to identify these patients in your practice and recommend and help them to the first step in their treatment, they're going to be coming back to you for that therapy, and you're establishing that trust and rapport with that group of patients. We have another group of patients where they go to their doctor's office and their doctor says, you should be on an iron, go get an iron, without a recommendation. They show up at your counter and they have no idea which one to get. That's an open slate for you to introduce this product, because you have all of the products in the shelf, and we know now that FERAPRO is the superior one. So take that as an opportunity, not just to recommend, but also to educate your patients on the different forms of iron, why this one might work better than the other one for that specific patient. And finally, we have our patients that come up and are buying their third bottle of Proferin. These are patients that I stop and ask, how is your iron therapy doing? And you would be shocked to hear that a lot of them are going to say, I've been taking this for 6 months and my ferritin has gone up by 4 points. It's not uncommon for me to stop patients in mid-transaction to realize that they're not getting the most out of their iron therapy. And it's really frustrating for those patients that are not just going through those side effects potentially, but also shelling out month and month over a lot of money for products that don't actually work for them. So lots of ways to introduce FERAPRO into the mix, and not just introduce FERAPRO specifically, but also to build that relationship with your patient, because you're going to be introducing to them a product that works, and they're going to be really grateful, their health is going to benefit, and they're going to come back to you. We know that your recommendation matters because in the history of this product, it's the practitioner success stories and the word of mouth that has driven sales. So FERAPRO began as Bob's Iron. It's something that Bob, our founder, made in partnership with a midwife that he was working with, because they just couldn't find an iron supplement that would be both tolerable and effective for her pregnant patients. And that was 20 years ago. And in that time, we've sold over 30,000 bottles without a hint of advertising, with $0 spent on marketing, just because of word of mouth. Practitioners will find that it works, and they will recommend it to their other patients. So this is a practitioner-driven product. It's not going to sell itself. You have to recommend it, but be confident in recommending it because it works and it's going to further your relationship with that patient. And I'm going to end now on some counseling pearls just to review what we've talked about in this session, to take away for your conversations with your patient. So again, iron is best absorbed on an empty stomach because it's strongly influenced by foods and other medications, but taking it with some food might be beneficial to offset the side effects until the patient is able to tolerate an empty stomach. Some foods are worse culprits than others, so we want to be avoiding dairy products, eggs, high fiber meals, of course coffee and tea like we talked about, and other medications by at least an hour before or 2 hours after. We want to recommend to our patients and to remind them every time that their ferritin levels should be rechecked after every 2 to 4 months. And it's convenient because one bottle of FERAPRO is exactly 100 capsules. So that's about 3 months. You can tell them once your bottle is finished, go back to your doctor, get your lab work done, see where you're at. Because we know that there is such thing as iron overload. And every other day dosing. So consider this because there has been recent literature to show that it is an effective clinical strategy for prevention of iron deficiency. So whether it's 30 milligrams every other day or 75 milligrams every other day, for your patients that you know are at high risk of iron deficiency, they have risk factors that you can't remove, don't let them get depleted over and over again. Do recommend that prophylactic therapy for these patients and have them be followed regularly through their doctor. All right, so I want to thank you so much for your patience and time with me today, and I'd love to take any questions that you might have.